Welcome back to Cath Outreach. My name's Scott. Today we're going to talk about using ultrasound to start IVs. So why use an ultrasound to start IVs? Well, for the ones who have large vessels that they're easy to stick, it's a waste of time to use that. Unless you needed to confirm the track of a certain vessel. We'll talk about that in a minute. But we see a lot of drug use. I work in the cath lab, and I was surprised at how much drug use makes it to the cath lab with vegetation on valves, endocarditis, those types of things. A lot of those patients have already used up a lot of their veins. So it's trying to find the vessels that they may not have been able to hit as easily, but you have access to with an ultrasound is very helpful. Critically ill patients, and some people are just poor venous access. If you have coronary artery disease, that's vascular disease that may affect other areas as well. It's going to reduce the number of sticks, and overall, it's going to reduce the amount of time it takes to gain IV access. If you have someone who takes 4 or 5 sticks, one, you have an upset patient, and you've wasted a lot of time on that instead of getting ultrasound and doing it quickly the first time. So let's talk a little bit about some of the ultrasound basics, and that's the abbreviation US. So ultrasound basics. Just a thin beam comes out of the bottom of that ultrasound. And we're talking about linear probes. I'll show you that in a moment. But you're only seeing what is under that. If you are moving, like we'll talk about tracking your needle here in a minute. If you're moving your needle but not moving that beam, you're not seeing the point that you need to be seeing. So it's a small slice that comes out, and only what's in that beam is visible on your screen. Let's talk about target veins. I start a lot of these in the cath lab, getting ready for procedures. And what I've found is this area of the forearm is a lot better. You have your basilic vein, and that becomes a larger vein, especially in this area where you see your midlines and your PICC lines put in there. But starting IVs on that, it's a larger vessel. If you hit the artery there, it's a larger vessel at that point as well. And it can be harder to get control of certain vessels if those start to bleed. So I really like to start my IVs down in this area. And this is just kind of the anatomy of that area. What you're looking for is 1.5 centimeters deep or less is the goal. But a lot of these get stable and about 1 centimeter deep running right through this area. You'll have a lot of twists and turns up here, bifurcations. I'll show you some of those. And these can come together. They can separate out again, kind of a reverse bifurcation, a fork in the road. So you'll see a lot to navigate up there in the AC area. But as you come down this forearm, these get to be that 1 centimeter deep, and you'll find that that's kind of your perfect setup for this type of access. And these tend to be very straight in that area. But what happens when we start overlaying our arteries with this? Remember, they are neurovascular bundles. So we're going to have nerves in this area. We're going to have veins and arteries. So the way you want to confirm it is the venous wink. That's the way I think of it. When you compress this vein, you see it right here. When you compress that vein, that should wink pretty easily. So when we're talking about identifying the anatomy, what you're looking for are veins that compress easily. Here's an artery, and we would want to avoid that unless you are starting an art line. But we're talking about venous access in this presentation. But here, it's not super obvious until you apply a little bit of pressure. And once you apply a little bit of pressure, you can see that pulsation. The pulsing, especially if somebody has bradycardia, can actually be a little bit, and low blood pressure can be a little bit difficult to detect. So sometimes putting just a little bit of pressure on that vessel will help you see the pulsing a little bit easier. You'll also see your veins collapse around that. Certain patients who have low blood pressure, you can collapse that artery with the same amount of pressure it does for the vein. So you do have to have a discerning eye with that. And the other thing, I can't honestly say I have hit one of these or knew exactly where that nerve was, but your nerves are non-compressible and they typically are a salt and pepper look. So this area right here is something that I would stay away from. If the vein was located underneath this, I might look for a different area, because a lot of times you'll find that the veins and the arteries are stacked up on top of each other. You'll see that they twist. You'll see T's, so it'll actually come in and it'll actually T. I've had that before. And that's that one where what you find out is all the lies or the fallacies that we as nurses have said for years and years when we miss an IV. All the vein wouldn't hold it. I don't know why that blew, but when you go and look with an ultrasound, you see why. You see that was actually a 90-degree T in there, and what you thought was a good vessel, you went right through it. You may have hit an artery because they can actually corkscrew around that, and at one point it's the artery on top, it's 2 centimeters up, it's the vein on top. So you learn those things when you use ultrasound. So what are you looking at on the screen? Well, we're looking for black compressible circles, which is our fluid, but bone and membranes will have that white look, and organs kind of have a little bit more of a gray look to it. So here's an example of tracking the arm up, the vein up the arm. As you put the ultrasound probe on the vein, you want to track up, and it should stay midline here. As you go up this vein, and you see the things changing in here as we move a little bit, what I'm doing on this picture here is I'm tracking up that vein to make sure that vein actually stayed straight in line with where my probe is. I've started IVs 90 degrees to the elbow and proved that it was in and had good draw and good flush, but it's not a typical look because it was exactly perpendicular to the way the arm went. But you can confirm those types of things with this. So as you go up the arm on this, if you are tracking right with that vein, then this is going to stay midline. When you see one of these things cross the screen left to right, that means that you're not tracking in line with that vessel. Here's an example of a bifurcation that comes in. So you can see it coming down from low here, and it'll come up. Redo it there. It'll come up and actually join. And then there's another bifurcation as well. So you learn about these things the more you do this. Here's an example of a 90-degree turn. There's the vessel, and here's the side view of a vessel. So as we moved up the arm, we saw this thing come in and actually make a 90-degree turn, or that's another branch coming into it, and that's a possibility. How do we know that? Well, when you look at long axis and short axis, let's say this vessel is not twisty turny like that one was. Let's say this is actually a straight vessel. When you are short axis, meaning your transducer is looking across that vessel, this is the view that you have. But if you centered that vessel in your window under your transducer, and you slowly turn that 90 degrees to where the transducer is lined up with the long axis of that vein, this will go from a circle to a vein to a line all the way across. And the reason that is this entire width of the beam is all seeing vessel. Here, the width of the beam is seeing both sides of the vein, the tissue on both sides, as well as the vein itself. But here we're lined up right on top of it, so we have this view. You'll see some websites that'll actually teach you to start IVs this way. And if you can, more power to you. What I find is that you've got about a millimeter beam that if you twist your transducer any, you're off that line. So you're trying to find that line, that beam coming out, and your needle right underneath that. So if you twist any, you turn any, you lose that view. It's much easier, especially starting out, in my opinion, to do the short axis. So when you're targeting this vein, having the right length IV catheter is very important. Here we have about a 1 1/4 inch needles as kind of your minimum if you're going to go for deeper vessels. If you're just confirming and it's right underneath the skin, let's say they had scleroderma or some type of connective tissue disorder where it's hard to palpate and see what you're going for, but you could look with that and see it. Maybe one of your normal IV length needles would work okay. But it's not uncommon to need a 3 or 4.5, almost 5 millimeter or centimeter length needle so that there's enough, you can go deep enough and the catheter will travel up that vein. One way to find this and to find your tip, there's a couple of different ways we'll talk about these, is just the 45-degree rule. If you are 1 centimeter back, say your vessel measures 1 centimeter deep to the top. And if you come 1 centimeter back from the beam, not the edge of the transducer, but from the center of that beam, you came 1 centimeter back and went at a 45-degree angle, your needle should come into view right as it contacts that vessel. So why use longer needles? Well, just the more depth that you have, this is how much catheter is still left in that in the vein. And we're talking centimeters here. So if you have a 1.5 inch or 1.5 centimeter deep and you go at 45 degrees, you're only going to have a centimeter of that catheter inside of that vessel. So it's one thing to consider, just a little longer needle. Like we said, the important thing is finding that needle tip. One of the things I like to do, and I'll show you a video of this, is I kind of fan that transducer back. So as I'm going for my needle, when I enter the skin, I actually have that tilted away from the needle. And then I'm looking back this direction to try to find my needle tip. The needle tip and the rest of that needle shaft look the same under ultrasound. So you have to know that you're watching that needle tip enter the screen. Your needle tip could be way through the vessel, but on your screen, you see a metal reflecting dot in the center of the vessel. Well, that's true, but what you're seeing is that shaft right here in the middle, not the tip that's all the way through. So one way of doing this is trying to find that, tilt your, fan your blade back or your transducer back to where you're catching that needle before it enters the vessel itself. And here's an example. You won't be able to really detect that, but here's finding that needle tip. So here's the needle tip coming in and you're watching it. Sometimes it's context clues. Here it is going in. You saw that tint right there. And here's this vessel, the needle in the vessel. You also see this little dissection plane. And sometimes, like in this case right here, I did not have flash yet, even though it looks like I'm in the vessel. So not abandoning your transducer and your attempt too early will save you a lot of times. So what I do on those is once I get in, I walk it up that vessel, and I'll show you an example of that here in a minute. But as you move the transducer up, you can watch that needle come into view, and you know you're seeing the very tip of it, and you're watching it walk up the center of that vessel. Here it is walking up that vessel. See, I'm clearly in. But as I move the catheter, or move the transducer up and watch that needle walk right in, and this will really increase your efficacy. Here we're kind of using context clues as this comes in. There's the needle. You see it tinting that vessel. You see maybe a little dissection plane there that you have to get through. Remember, your veins have 2 layers, so it's not uncommon to get in between those. And it looks like you're walking up this vessel and you should get flash, but you don't get any. That's because you're not in the true lumen yet. So making sure you have flash and you walk this up a little bit will improve your success rate. And that's the example that we have of starting that, especially when you're in the vessel and you're walking up. If you are moving your needle and you've not moved your transducer, your view has changed and you're not appreciating that. So what I like to do is move my transducer ahead of my needle and watch my needle tip come into view. And that's an easy way of tracking that. Set yourself up for success. I remember when I worked in the ER, it was not uncommon to kind of squat down and hold their arm down, and you're in these crazy positions. I worked on a helicopter, and you get a lot of crazy positions with trying to get IVs in some of the smaller aircraft. That's not the case in this. We're in a cath lab room. We're in a pre-op room. We're in an ER room. Let's get this person on an arm on a Mayo tray. Let's get it up where we can actually reach everything, stand up, and actually use this. So here we've got everything we need open and ready for us. I always assume I'm going to get one look at this, because just because you find it and you're like, okay, this is where I'm going to go, you put everything down, you clean the whole site, you put the jelly on, all those types of things, doesn't mean you're going to find that same view as easily. So what I do is I clean that whole area. I put a protective cover. It's not on this a older system here, but I'll have it use a protective cover on the over the ultrasound so it doesn't get contaminated between patients. Remember, air is your enemy in this, so you'd want to have some sterile lubricant on the transducer tip before you put that cover on it, and then you'll need the sterile lubricant over the tissue, over the skin, to make sure there's no air in there. The sound waves cannot see through air, so if you ever have this big gap in on your screen, you're not seeing an area, that's probably a big air bubble between the transducer and the skin. But here, this nurse can look across and see the screen very easily, and the vessel. And that's the difference, because you're not watching your hands like you do with a regular IV. You're doing, one hand's doing one thing, the other hand's doing another, and then your eyes are actually across the room or wherever your screen is, and that's what you're watching. So it takes a little bit of getting used to, but the more you have everything out, open, and ready, the better off you'll be. So the kind of technique that I like to use on this, I like that short axis approach. Make sure that the depth is appropriate. Make sure the vessel is straight for the length of the needle that I'm going to use. Do a compression test and make sure that vein will collapse easily and there's no arteries right there beside it, or no arteries in the way. I move the probe up and down, make sure it stays straight. Insert your needle at the proper angle. Find your needle tip. Watch for that tenting, and then walk your needle tip up the vessel. Some patients it's very hard to find your needle tip, and that's not just a body habitus. I don't know if it's how they store their minerals. I don't know. I've seen large people and skinny people difficult to find my needle tip inside of them. So I don't know what changes that. Sometimes there's power settings you can adjust on your particular ultrasound that you're using. Another thing you want to do is make sure your transducer is oriented with your screen. This gray bar on the side of the transducer aligns with this P for Philips on this particular product. But so if it's on the left, you want your gray bar on the left. Really, though, all you have to do is touch just one side and make sure you see some deflection there of the ultrasound to know that the left side of the screen is the left side of the transducer and the right side is the right. Here's an example of a needle tip being tracked. As I move forward, I move the transducer forward and watch the needle come into view, so I know that I'm always watching the most distal tip come in. I see the tenting, and we see it drop in. Just do a little wiggle test here. This is all artifact, but notice artifact doesn't move tissue. So if you do a little wiggle test there, you're only going to move the tissue itself. That'll help you differentiate from artifact if you're seeing that. This one here is a hockey stick transducer, and there's a marker there for center line and a marker there for center line, depending on how you're using that. And you also have a linear probe. Some of the linear probes are fancier. They have buttons on there to control different things that you don't have to break. Have a bloody glove and reach over and touch anything. You can have a protective sleeve over top of that transducer and be able to make some manipulations. So it just all comes down to the type that you have. So here's color and depth, depth and center line that you can adjust. I like a 2 centimeter depth. And then there's usually a center line that you can put on. So color is something that's on most of these as well. And once you select color, it'll give you a square. And on that square, you can adjust it. You can move it around to interrogate the area that you want to interrogate. And the way you know which direction the flow is going is blue, the acronym BART, blue away, red towards. So you can actually change that. If this is the vessel and you actually change the way your transducer is aimed, if blood is flowing towards the tip of my finger and I will aim the transducer this way, then blood is actually going to be coming towards my transducer. So that's going to be red because it's coming towards it. If I take my transducer and I flip it over a little bit, now the blood that it's seeing is going away from it, and that's actually going to be blue. So it's not blue as vein, red as artery. It's blue is going away, the flow is going away from it. That's kind of the Doppler effect. You know, this thing is sending out these sound waves and it's analyzing this. So as those signals come back, they're coming back with less velocity because that fluid's going away from it. Whereas the ones where the blood is coming towards it is coming at a faster velocity than it left at because the blood's coming towards it, bringing it back even faster. So BART, blue away, red towards. And then finally, there's pulsed wave. And what this does is it gives you a little marker to put on the vessel that you want. You can hit it again, and now you see it sweep going across the bottom. And what that does is it'll help you show pulsatility. So if is this an artery or is this a vein? Just another way of doing that. You can also do that with heart valves. You'll see that if you ever study echocardiography. That's a big thing with that as well. But just for as far as starting IVs, or even helping doctors get access in femoral arteries, since ultrasound's the standard now, you can actually every once in a while they'll ask and say, "Hey, will you put that on pulsed wave?" And what that does is that sends out a signal, analyzes it, sends out a signal, and analyzes it, and you can actually get that waveform on the bottom to see is it pulsatile or is it not. All right. That's kind of an introduction to ultrasound IV. I hope that was helpful. The more you train and the more you use this, the better off you're going to be. If you actually take this the first time and just find the vessels and then lay it down and do normal IV, you're one step closer to becoming more comfortable with this. I don't understand why certain places will take it away because it's like one place took it away because there was infiltrations. Well, how many blind stick IVs infiltrate as well? Becoming proficient at this takes time. It's nerve wracking that first time. The patient does not need to know this is your first time trying that. As far as they know, this is your 1 millionth time doing this. But being comfortable and confident, but practicing with this. In the description, I'll have a link to some models that you can make. If you want to actually buy some of the trainers, those can be $700-800. There's actually a model out there that you can make it out of gelatin, and one of the videos that I shot on there actually was that, where I tracked that needle in. But that gelatin actually looks very similar to what the tissue looks like underneath. We use a Penrose drain in that, and you can actually practice this for very, very cheap. All right, I hope that was helpful. We'll see you next time.